And so today my video lecture is on a somewhat complicated topic, that is I'll be talking about transesophageal echocardiography for cardiac malposition and heterotaxy. Myself, I am Dr. Rishabh. I am working as an assistant professor at the Department of Cardiac Anesthesia, UNMICRC Institute of Cardiac Sciences, Ahmedabad. Now coming to introduction. So firstly, the term cardiac malposition, it refers to an abnormal position of the cardiac mass within the thorax and is generally associated with an abnormal base to apex orientation of the heart, which can be found in a wide variety of cardiac anomalies, and the underlying common feature, however, is the abnormal position and orientation of the heart. In this context, we will be using different terminologies such as levocardia, dextrocardia, dextroposition, dextroversion, mirror image dextrocardia, mesocardia, isolated levocardia. So all of these terms are very confusing terms, and I'll try my best to elucidate each of them. Now coming also to another important term, that is heterotaxy or atrial isomerism, whereby there is laterality or sidedness abnormal with defective embryologic right-left axis patterning causing visceroatrial situs ambiguity, which causes abnormalities in multiple lateralizing organs. So here we have to take note of each of the words here. That is, firstly, there is defective embryologic right-left axis patterning. Secondly, the important term to note here is visceroatrial situs ambiguity. So we will be discussing all these terms in detail in the subsequent slides. Coming to what all are the different cardiac malpositions that we see. So if we can categorize all the different cardiac malpositions, we can categorize them mostly in terms of the position of the heart and in terms of the axis of the heart, that is, in which part of the hemithorax the heart is located and the orientation of the base to axis orientation of the heart. So the normal orientation is also known as levocardia, where the position of the heart is to the left of the midline, that is, most of the heart is located in the left hemithorax as is seen in the accompanying picture. And the axis of the heart, that is from the base of the heart to the axis of the apex of the heart, is from the right side to the left side. So depending on this normal configuration, now we can categorize the different abnormal configurations. The first abnormal configuration is dextrocardia, also known as primary or isolated dextrocardia, where only the issue is with the orientation of the heart. So the heart will be located to the right of the midline, but the situs of the patient will be situs soleus. Axis of the heart will be reversed, that is left to right. Secondly, the term is dextroposition or secondary dextrocardia, where the normal axis of the heart, that is right to left, is maintained, but the most of the heart tissue is located to the right of the midline. The next term, which is not that commonly used, is a term known as pivotal dextrocardia or dextroversion, which is mostly similar to primary dextrocardia, whereby the heart is positioned to the right of the midline, situs soleus is maintained, and the axis of the heart is left to right. But in the interest of clarity and to avoid confusion, this term is less used nowadays. Now coming to the next term, that is mirror image dextrocardia, where the position of the heart is to the right of the midline and the situs is situs inversus. So we will be dealing with all these terms in the subsequent slides. The axis of the heart in mirror image dextrocardia is reversed, that is left to right. Mesocardia is a unique abnormality where the position of the heart is neither to the right nor to the left, rather the most of the cardiac mass is located along the midline and the axis of the heart is therefore also midline. And again, another important terminology is there, that is isolated levocardia, where the heart is located to the left of the midline as in normal, but the situs is either inversus or ambiguous. Here also, like in levocardia, the axis of the heart is right to the left, that is, the heart is maintaining the normal position, normal orientation, but the rest of the organs are abnormally oriented. Now these are the different cardiac malpositions. Coming to the next topic, that is a very important topic, that is the visceral situs. So visceral situs refers to the internal organ layout of the human body, not just of the heart but of also different organs such as the liver, stomach, aorta. So situs soleus, which typifies most humans, is a configuration where the liver and the IVC, that is the inferior vena cava, are on the right, The stomach and the aorta are on the left side and the heart lateralizes to lie in the left chest. Now coming to the abnormal conditions, that is situs inversus, where these organs they lateralize to the opposite side and are commonly associated with dextrocardia. Another important term is situs inversus totalis, where there is mirror imaging of the lungs and abdominal viscera with mirror image dextrocardia. That is, all the major bodily organs are reversed in orientation. Now, there are numerous genes that are linked to right-left patterning and heterotaxy, including nodal, ZIC3, CFC1, LEFT2, FOXH1, ACVR2B and NKX2.5. Also, there are certain environmental modifiers such as maternal diabetes and monozygotic twinning. All these have been associated with the heterotaxy spectrum defects. So, heterotaxy is quite a complex cardiac lesion, and there are a number of limitations when we get to do the TE examination of such patients, but using a structured approach, as I will be discussing subsequently, we can examine and we can determine the anomalies. Now coming to the different types of atrial situs. So this is one of the most important slides. So here we can see on the top left there is the usual orientation, that is the situs solitus, that is the left atrium is located to the left of the right atrium, and as we can see in this slide itself, the morphologies of the two atria are markedly different. That is especially with respect to the atrial appendages. That is, the left atrium, it has an appendage that is finger like, which is narrow, and the right atrium has a broad based appendage, and the right atrium also has trabeculations. So that is how, these are the major points by which we can distinguish morphologically between the left and the right atrium. So in the usual configuration, that is situs solitus, the right atrium will be to the right of the left atrium, or we can say the left atrium will be to the left of the right atrium. The opposite will be true in case of mirror image, where the morphological LA will be to the right of the right atrium. Now coming to isomerism. Now isomerism, as we can see, it's obvious in this image that there can be either two configurations of morphological right atrium bilaterally, or there can be two configurations of morphological left atrium bilaterally. So this is a pretty complex cardiac lesion, and we will be examining this in detail in the subsequent slides. Now coming to heterotaxy. Heterotaxy, as I have discussed in the previous slides, is an abnormality of laterality or sidedness with paradoxically bilateral visceroatrial symmetry, and heterotaxy belongs to a class of genetic ciliopathies which are characterized by abnormalities or dysfunction of primary cilia on the embryonic node during cardiac embryogenesis. So heterotaxy has an incidence of 1 in 10,000 live births and accounts for around 3% of all CHD. Here it is important to note that it is one of the most highly heritable of all the cardiovascular malformations, with an estimated 10% of patients having a close family history of congenital heart disease. Despite numerous potential variations, the heterotaxy patients tend to be classified into two main types, that is either right isomerism, or that is also known as bilateral right-sidedness, which is also known as asplenia, or left isomerism, which is also known as bilateral left-sidedness, also known as polysplenia. So in the interest of convenience, in the interest of avoiding confusion, the working group of the International Nomenclature Committee for Pediatric and Congenital Heart Diseases have noted that heterotaxy does not include situs solidus or situs inversus. So here we will be dealing mostly with right isomerism, that is asplenia, and left isomerism, that is polysplenia, and we will be discussing the T evaluation of patients with such lesions. As we can see in the image on the right, we can see the different types of isomerism and the manifestations of the isomerism. So with respect to the lung, with respect to the spleen, the stomach, and the liver, as well as the configuration of the bronchi. Now these are the different features of right versus left isomerism. So each of the organs is having specific manifestations. More importantly, we can refer to the liver. Liver is midline or midline symmetric in right side, where it is asymmetric. It can be asymmetric or symmetric in the left side. Lungs, bilateral trilobe lungs in case of right isomerism, while bilateral bilobe lungs in the case of left isomerism. So similarly, spleen is absent in case of right isomerism, but spleen is usually multiple in case of left isomerism. Cardiac position in both will be dextrocardia. and there will be significant differences in the systemic and pulmonary venous drainage also. So we can summarize the entire findings of right versus left isomerism in this table. Now coming to the TE evaluation, that is the basic principles. So heterotaxy patients, as I have already discussed, with congenital heart disease can be among the most challenging to evaluate by echocardiography. However, the TE imaging parallels any patient with complex CHD. So we need to perform a detailed and systemic evaluation of the entire cardiovascular system, particularly in those patients with unknown or uncertain anatomy. And the TE evaluation of heterotaxy is quite complicated, but it needs to be relevant to the important surgical questions that must be answered to the proposed surgery. So mostly we may have to go for a single ventricle palliation in these patients, but some of the patients may have findings that merit a biventricular repair. So that is one of the important questions that needs to be addressed during TE evaluation. Specifically, the examination should be systematic and thorough, guided by the principles of segmental approach to CHD evaluation. So what is the segmental approach? So we will be discussing segmental approach in the subsequent slides. So the segmental approach to CHD evaluation was described first by Van Praag and Anderson, and the segmental approach is a methodology that emphasizes the importance of visualizing structures. In case of a case of a normal TE examination, what we do is we go by different standardized views, but in this case we have to go not via views or via standardized views, but we have to go through evaluation of various structures. So it is a structure-based evaluation, and it is necessary to identify each cardiac structure separately and individually in terms of cardiac segments. This is even more important because the cardiac structures will not be in the usual or expected positions, and therefore standard TE views might not present the cardiac anatomy as would be normally expected for these views. However, the actual TE examination need not be extensive and can be tailored to the most important anatomic and physiologic features that require evaluation. Now, this is in short how we perform a sequential segmental evaluation of any patient with congenital heart disease, and even more importantly for patients having heterotaxy and cardiac malpositions. So first and foremost, we will be establishing the cardiac position, whether it is levocardia, mesocardia, dextrocardia. Thereafter, we will be establishing the visceroatrial situs and atrial anatomy. Thereafter, we will be determining the systemic and the pulmonary venous return. Thereafter, we will be evaluating the atrioventricular connections and valves. Thereafter, we will be evaluating the ventricular morphology, chamber size, and the ventricular septum. Then, we will be evaluating the ventriculo-atrial connections, outflow tracts, and the semilunar valves. Then, we will be proceeding towards the great artery position anatomy relationship. Finally, we will be evaluating the coronary artery anatomy, and also we will be evaluating the biventricular function, that is both systolic as well as diastolic function. So this is a summary of the entire sequence of evaluation of any patient with heterotaxy and with cardiac malpositions. Now, before we get to the details regarding examination, I'd like you to know certain tips and tricks so as to optimize the TE evaluation. Firstly, the echocardiographer will mostly be encountering a patient who has either undergone multiple investigations, imaging investigations, or may have undergone multiple staged surgical procedures in the past. So it is important for the echocardiographer to be reviewing all the previous imaging studies, to be familiar with the specific anatomic and physiologic features of the particular patient so as to be familiar with what to expect. Secondly, the standard TE views, they serve merely as a point of reference. As we know, the anatomy can be hugely distorted in all these patients, and therefore the names of the individual views might not accurately characterize the actual structures evaluated. Also, these TE views have to be adapted or altered considerably in order to provide meaningful understanding of the patient's anatomy and physiology. And non-standard views have to be obtained in most of the cases. Also, the position of the esophagus and the stomach related to the heart may preclude an effective TE examination. So this is one of the limitations of transesophageal echocardiography, that we are limited to the position of the probe within the esophagus. So if the esophagus and the stomach position relative to the heart are not normal or not optimal, then that can adversely affect the TE examination. Nonetheless, most of the patients we can perform a detailed TE examination even in the context of abnormal anatomy. So there is not one prevailing or standard methodology to evaluate the cardiac malpositions and heterotaxy. Each heart is different, many are unique, and no universal template applies. So these are only the guidelines that we follow, but each patient will be requiring a tailored approach depending on the findings of the echo examination. Also, very importantly, as we are here dealing with abnormalities of right and left lateral orientation, so the probe transducer orientation should be very much monitored, and we must be mindful of the right to left orientation, and the position of the probe should be noted, and it should never be reversed. The right left orientation on the screen must never be reversed. Where the right left orientation is not apparent on the screen, it can be helpful to annotate on the screen the left right position of the TE probe. Now coming to the start of the examination. So firstly we will be looking at the cardiac position, the situs and the atrial anatomy. So at first we will be starting with a view that we are all very familiar with, and that can serve as a home view. So we can start the examination from the home view, and then we can proceed with the examination. Suppose the echocardiographer gets lost and the views desired are not being able to be displayed accurately, then we can always come back to this home view. So in this case, the home view will be the mid-esophageal 4-chamber view. So the mid-esophageal 4-chamber view is a very useful view because it can provide a large amount of information in one go. We can determine the orientation of the cardiac apex as well as the position of the heart. So that can be best viewed using the mid-esophageal 4-chamber view. So another view that we can use in this case is the deep transgastric 5-chamber view, because as I've already told, these views display both the base and the apex of the heart with the same field of view, and while the position of the esophagus is normally midline, the position of the esophagus stomach can vary along with the heart. So the actual location of the heart in relation to the thorax may or may not be evident by TE. As we can see in the slides on to the right of the screen, so the mid-esophageal 4-chamber view in a patient with visceroatrial situs soletus, D-loop ventricles, and there are normally related great arteries. It can be appreciated using the different TE views. Also similarly, as I have shown in the pictures on the right, the deep transgastric view can also be used for this situation. Now coming to the visceroatrial situs, that is how to determine. So firstly, as I have already mentioned in the previous slides, the characteristic morphologic features of the atrial appendages will serve to distinguish the morphologic right atrium from the left atrium, and the morphology of the atrial septum when present will help to identify the individual atria. The atrial situs, from the morphology, it can be estimated like that. Also we can determine the sidedness of the atrial chambers by looking at the draining vessels. So for example, we can see the suprahepatic portion of the IVC and the coronary sinus drainage, that is the chamber into which the inferior vena cava drains, that can be termed as the right atrium, while the chamber into which the coronary sinus drains, that can be denoted as the left atrium. But that is possible only for patients with normal anatomy. Here we cannot assume anything. We have to look at each of the chambers, we have to look at each of the vessels, and most importantly, we have to look at the point of connection of these great vessels to the cardiac chambers. So for atrial situs, that can be established firstly by determining the morphologic features of the atrial appendages. Secondly, the morphology of the atrial septum, that is the septum secundum versus the septum primum. The septum secundum will be present towards the right atrium, and the left atrium will be the left atrial appendage will be having a finger-like appearance, while the right atrial appendage will be broad-based and triangular. Secondly, the visualization of the suprahepatic portion of the IVC in the coronary sinus drainage, which is commonly done by a modified transgastric IVC or hepatic veins view. So here we have to visualize the actual site of IVC entry into the heart, because the visceroatrial situs in patients with heterotaxy can be ambiguous, and irrespective of the IVC position in the abdomen, the drainage into atrium can be quite variable. Also, it is important to confirm that an IVC is indeed present, as many patients with polysplenia can have an interrupted hepatic portion of the IVC, in which case the azygos or the hemiazygos vein will return the venous return from the lower part of the body into the SVC. And even when IVC is present, it cannot be assumed that all the hepatic veins drain directly into it, because some of the hepatic veins may drain into the IVC while the other hepatic veins may drain directly into the atrium. This is important especially where a fontan palation is planned, because if such abnormal communications remain, then also after fontan palation there can be significant cyanosis. Once the identity of the R and LA is established, the atrial anatomy should be evaluated with particular emphasis on number of atria, septal morphology as well as the atrial size and position. So these are the different TE views that we can use, and in this case we are seeing on the top left, we are seeing the midesophageal bicaval view. Here the patient is having atrioventricular discordance, that is the RA is emptying into the LV, and there is the presence of RAA. We can see that clearly, and on the bottom part of the image, that is the midesophageal the transgastric IVC hepatic veins view, whereby we can see the IVC draining into the RA. Now coming to one of the rarer anomalies that we see, that is juxtaposition of atrial appendages. Here we can see that both the right atrial appendage and the left atrial appendage are located on the same side. A little bit of probe retroflexion has been done on the image to the right. The image to the left shows the presence of the RA and the RAA, while the image to the right shows the presence of the LA and the LAA. Now coming to the systemic and the pulmonary venous return. Coming to systemic and pulmonary venous return, we have to take into account that the systemic and the pulmonary venous drainage eventually returns to the atria, and therefore it can be performed concomitantly with the atrial morphologic assessment. The evaluation should be done systematically with special focus on sites of drainage of each venous system. Like I have told, we cannot assume anything with regard to the anatomy, and we have to focus on where the great vessels are emptying into each cardiac chamber, so as to determine whether or not the venous return to the heart is normal or abnormal. And the patients with heterotaxy can have considerable variation in venous anatomy. So some of the more common anomalies can be bilateral SVCs, absent coronary sinus, partial or total anomalous pulmonary venous return, variable IVC drainage, as well as interruption of the intrahepatic portion of the IVC. Evaluation of the systemic venous return can be done both by means of 2D imaging as well as by using color flow Doppler evaluation for unusual flow patterns. So in terms of IVC, what we can see is the presence or absence, the position in the liver, whether all the hepatic veins are draining into IVC, and the drainage side of the atrium. With regard to SVC, whether there is one or two SVCs, what are the drainage sides of the SVCs, and if there are two SVCs, whether there is a bridging on an innominate vein. Coming to hepatic veins, whether they all drain to IVC or do some or all of them drain directly to atrium. Coming to coronary sinus, presence or absence, if present, where it drains and whether it is dilated, and whether the dilation is due to SVC drainage to the coronary sinus or anomalous pulmonary venous drainage. Also, we may have to examine the azygos and hemiazygos veins. Usually the azygos and hemiazygos veins are little bit difficult to evaluate using TE, but where the hepatic portion of the IVC is interrupted, it is necessary to examine the azygos and the hemiazygos veins. Now coming to the careful interrogation of both the left and the right, as well as the mid and the upper esophageal views have to be performed to evaluate for the presence of SVCs, and if bilateral SVCs are identified, like I have told many times, the location of drainage into the atria should be noted. If intravenous access is available in the right and left extremities of jugular veins, we can perform agitated saline contrast in determining the drainage sites of the SVCs, and also to evaluate the presence of any defect in the atrial septum, we can use agitated saline contrast. Now for evaluation of pulmonary venous drainage, we have to perform firstly color flow Doppler mapping to establish the exact location of pulmonary vein drainage. Also we can use color flow Doppler to determine any pulmonary venous obstruction, following which further evaluation using spectral Doppler interrogation is performed. Using a combination of the right midesophageal right pulmonary veins and the midesophageal left pulmonary vein views, the individual pulmonary veins can be identified and evaluated as they drain to the heart. It is also important to identify the individual left and the right pulmonary veins and then determine whether all the pulmonary veins drain to one atrium, separately to ipsilateral atria, or anomalously to a systemic vein. So all these variations may be seen in these patients. Using spectral Doppler, both systemic and pulmonary venous flow patterns should be normally continuous and low velocity with variation during the cardiac cycle. Unusual higher velocity flow entering a systemic vein should indicate anomalous drainage of one or more pulmonary veins into the vessel. And also the venous drainage below the diaphragm should be evaluated to rule out infracardiac TAPVC. These are the different views that we can use in order to evaluate the systemic and the pulmonary venous drainage. That is the top left image. It shows again the modified transgastric IV's hepatic vein view, whereby it is seen that the hepatic vein is draining into the IVC, and also the lower part of the slide where we see the presence of the azygos vein as well as the presence of multiple hepatic veins. Also, another mediasophageal left pulmonary vein view here that we are seeing is the presence of an LSVC, and as a result of the LSVC the coronary sinus is dilated. And the next image to the right is showing a modified mediasophageal left pulmonary vein view, whereby the LSVC is returning to the left atrium directly because of the presence of an unroofed coronary sinus. Now coming to the next slide, that is showing the modified transgastric IVC hepatic vein view, and it has been withdrawn to the mediasophageal four-chamber view. And here we are seeing the entrance of the IVC into the RA. And when we withdraw the probe further, we can see the pulmonary veins returning to the RA, and that is what we can see in this image. Thus, we can evaluate the pulmonary veins both by using color flow Doppler as well as 2D imaging as well as spectral Doppler. Now coming to the next segment of the heart, that is the atrioventricular valves and the ventricular assessment. Since the atrioventricular valves develop from the ventricle's entry, therefore the evaluation of AV valve anatomy of function and the ventricular morphology are interrelated and should be performed together. Here we have to know the presence of concordance or discordance. So the basic principle here is that the atrioventricular valves are related to the ventricles into which they empty. So usually the mitral valve will be draining into the morphologic left ventricle, while the tricuspid valve will be draining into the morphologic right ventricle. So the assessment of the AV valves and the ventricles can therefore be performed together. So in patients with atrioventricular concordance, the left atrium will be emptying into the left ventricle and the right atrium will be emptying into the right ventricle. That is left atrium through the bicuspid mitral valve to the morphologic left ventricle, and the right atrium to the morphologic tricuspid valve to the morphologic right ventricle. However, in patients with atrioventricular discordance, it will be configured in such a way that the left atrium will be draining into the right ventricle through a morphologic tricuspid valve, while the right atrium will be leading into the left ventricle through a morphologic mitral valve. So the first determination will have to be seen is whether there are one or two AV valves present, especially in patients with atrioventricular canal defects. There may be a significant percentage of patients who will be having a common AV valve, especially in case of complete atrioventricular canal defects. Also, if two atrioventricular valves are present, the determination must be made as to which valve is tricuspid and which is mitral, based upon the specific anatomic characteristics including the valve architecture, tensor apparatus and the papillary musculature or morphology or attachments. That is, mostly we have to determine using the morphology which is the tricuspid valve and which is the bicuspid valve, that is the mitral valve. Tricuspid valve usually will be having 3 leaflets, and the tricuspid valve is usually having attachments to the septal, to the ventricular septum. That is, the tricuspid valve is septophilic, while the mitral valve does not have such septal attachments, and the mitral valve is usually septophobic. Also, the mitral valve is usually oriented little bit superior compared to tricuspid valve. So we can easily determine the valve identification by using these simple points. In addition to the 2D assessment, we have to perform the color flow and the spectral Doppler assessment. We have to determine the presence of any AVVR, that is AV valve regurgitation, especially in case of a common AV valve, and also whether any AV valve stenosis is present. So this will also help us to determine whether a single ventricle palliation or whether a biventricular repair is feasible. And in patients with a common AV valve, if consideration is given to a possible biventricular repair, it has to be determined whether the AV valve is well balanced over the both ventricles. In addition to determination of the ventricular morphology, we have to determine the ventricular size, shape and function. Papillary muscles should be carefully noted, and also any presence of ventricular septal defect should be evaluated. Also, whether there is any overriding or straddling AV valve chordae, that is also one thing that should be seen. So, assessment of these structures is done by using the midesophageal as well as the transgastric views. With respect to the right side of the heart, a modified midesophageal right ventricular inflow-outflow view is especially helpful because it displays simultaneously the inflow apical trabecular as well as the outflow portions, and also provides excellent visualization of the membranous and the perimembranous portions of the ventricular septum. While the AV valves can be visualized from deep transgastric views also, the midesophageal and the transgastric windows generally provide better imaging for the physiologic assessment of AV valve stenosis and regurgitation while utilizing color flow and spectral Doppler. However, we must always keep in mind that the cardiac malposition can result in markedly unusual positioning of the cardiac chambers, which in turn can lead to an atypical location appearance of the atria, atrial septum and the ventricular septum and the ventricles. So, as I have repeatedly told, we must not assume anything regarding the anatomy of the patient, and the TE assessment should be structure based and not view based. So that can be also be accurately pointed out in the images on the right side, whereby we are seeing a midesophageal 4-chamber view in the top image, and we are seeing another midesophageal 4-chamber view whereby there is a large inlet ventricular septal defect. Now coming to the next set of images, this is a transgastric basal short axis view of the mitral valve in a patient with dextrocardia and tricuspid atresia, and in the image to the right we can see a deep transgastric view in a patient with situs solitus viscoatrial and congenitally corrected transposition of the great arteries. That is, there is both atrioventricular and the ventricular arterial discordance. Now coming to the next set of images, where we are seeing the presence of a deep transgastric right ventricular outflow tract view in a patient with heterotaxy and double outlet right ventricle as well as subpulmonary and pulmonary valve stenosis. And here we can see the relationship of the ventricular septal defect of the great arteries. Also, we can see the spectral continuous wave Doppler velocity across the pulmonary valve in the image on the right side. Now coming to the ventricular arterial junction in the outflow tracts, this is yet another important part of the full segmental evaluation. At first, we must identify the great arteries and we must assess them for the possible outflow tract obstruction, and the relationship of the great artery should be determined, particularly in relation to the VSDs. The ventricular arterial and the outflow tract relationships need to be established in the context of the contemplated surgery, particularly if the biventricular surgery is planned. Also, the evaluation is aided by the fact that the TE imaging of this area is usually excellent, and the one thing that we need to keep in mind is that the standard transducer angles may need to be varied to achieve the optimal visualization. The deep transgastric views are also very important in the context of intracardiac baffling and biventricular repair. They also provide an excellent angle of insolation for spectral Doppler assessment of the outflow tracts, and for evaluation of semilunar valves, the right-left orientation of the semilunar valves and relationship with the valves to each other can also be done with the help of midesophageal aortic valve short axis view and the deep transgastric 5-chamber views. And the semilunar valve diameters need also to be measured by means of the midesophageal aortic valve long axis inflow outflow and the midesophageal long axis views. These are different images which show the TE views of the ventricular arterial junction and the outflow tracts. Again, we are seeing here evaluation by using color flow Doppler as well as by using spectral Doppler across the RVOT. And the image to the lower right is showing a patient with dextrocardia and viscoatrial situs inversus and inverted normally related great arteries. Now coming to the next set of images, this is a midesophageal long axis view in the patient which is having dextrocardia, viscoatrial situs inversus, DORV, subpulmonary pulmonary valve stenosis. So as we can see, in most of the patients with heterotaxy and cardiac malposition, there will be multiple cardiac anomalies superimposed upon each other. So it is all the more important to adhere strictly to the sequential segmental examination and to proceed by using a structure based evaluation. Now coming to finally the evaluation of the great arteries and the coronaries. great artery evaluation, unlike the ventricular arterial segment, is problematic because of the variability of available windows. However, we have to determine the following. Firstly, we have to assess the aortic arch sidedness. We have to determine the branch pulmonary artery continuity. We have to determine the identification of the aorta and the main pulmonary artery has to be done, and also presence or absence of any patent ductus arteriosus. So mostly we have to use here the upper esophageal views, that is upper esophageal arch long axis view for determining the aortic arch sidedness, upper esophageal pulmonary artery view for the pulmonary artery in the PD assessment, upper esophageal aortic arch short axis view for evaluation of the aortic arch size in the PDA if present. For all the upper esophageal views, transducer sweeps will be necessary. That is not just one view, but we have to move the transducer and we have to determine the continuity of each of the cardiac structures on the evaluation using a combination of clockwise, counterclockwise and advancement withdrawal transducer to develop an understanding of the three-dimensional anatomy. An important aspect of the TE evaluation, the coronary arteries, is that as with all other aspects, we have to be mindful of the right-left orientation, proper identification of the great arteries and the probability of the unusual positioning of the great arteries relative to each other. Now, these are some of the TE views that are showing the TE views of the great arteries. That is, firstly, the upper esophageal pulmonary artery view, that is showing the main pulmonary artery bifurcating in the LPA, that is the left pulmonary artery and the right pulmonary artery. Also, on the image on the right side, there is an upper esophageal aortic arch short axis view showing a right aortic arch arising from the undersurface of the aortic arch and connecting to the main pulmonary artery or the right pulmonary artery. Coming to the mid-esophageal aortic valve short axis view in the patient with dextrocardia, situs inversus, double outlet right ventricle and the subpulmonary pulmonary valve stenosis. This view is showing the aortic valve anterior to the left of the pulmonary valve and the origins of the LCA and the RCA from a single right-facing sinus. The image on the right side is showing the origin of the LMCA, that is the left main coronary artery, in a patient with dextrocardia, situs inversus and inverted normally related great arteries. So to summarize, in cases of cardiac malposition and heterotaxy, the abnormal positioning of the cardiac chambers, systemic and pulmonary venous return, and the outflow tracts sometimes requires an unconventional or unorthodox surgical approach with some degree of surgical improvisation. Therefore, the echocardiographer has to adapt accordingly. The echocardiographer should optimize the imaging based on cardiac position and structures imaged. The standard TE views will also likely need to be adapted to visualize the appropriate structures and physiology. So as I have told repeatedly, there is not one standard TE approach to evaluation. Instead, a systematic segmental approach is important and is recommended to develop an understanding of the patient's underlying anatomy and physiology. And also, as we have seen in all the preceding images, patients with heterotaxy, they tend to have multiple cardiac defects located at different segmental levels. That is, like they may be having defects at the draining veins, they may be having defects at the atrial level, at the level of atrioventricular valves, at the level of ventricles, ventricular arterial junction, and the great arteries as well as the coronary arteries. So, the evaluation should be similar to any cardiac malposition, and a careful and open-minded evaluation should be done in all such patients with no prior assumptions. Coming to the end of my presentation, thank you all for your patient listening.